Hey everyone and welcome. Today we're going to pop the hood and take a look at the owner's manual for one of the body's most critical systems, the urinary system. We're going to break down some of the most common issues that urologists see every day, from those tiny, excruciating stones to the complexities of the prostate. So let's just dive right in.
All right, to get us started, let me ask you something. Think about a pain so bad, so sudden, that it literally drops you to your knees and sends you straight to the ER. What do you think that could be? Now, while you're thinking about it, here's a hint. The answer is surprisingly small.
And yeah, you probably guessed it. The answer is kidney stones. These things are basically tiny, unwanted guests, little crystals that form in your kidneys. And believe me, when they decide it's time to move, you are definitely going to know about it. It's one of the most painful things a person can go through.
Now, what's really interesting is that not all stones are the same. It's not a one-size-fits-all problem. And you can see here the overwhelming majority, we're talking 75%, are calcium oxalate stones. But knowing the exact type, whether it's that or, say, a uric acid stone or an infection-related struvite stone, is absolutely key to figuring out how to treat it and, just as importantly, how to stop it from happening again.
You know, with kidney stones, it really is all about location, location, location. If that little stone is just hanging out in the kidney, not moving, you might not feel a thing, or maybe just a dull ache. But the second it moves into that narrow tube, the ureter, oh boy, that's when you get that intense, wave-like pain. And then, if it makes it to the bladder, the pain changes again. So, how in the world do doctors figure out what's going on inside you? Well, you'd be surprised. The biggest clues actually come from a really simple urine test. The chemistry of your urine is kind of like a fingerprint. It can point doctors right to the type of stone that's causing all the chaos.
And one of the biggest chemical clues they look for is pH. Think of it like this. If your urine is really acidic, we're talking a pH under 5.5, that's a huge hint that you're dealing with uric acid stones. But on the flip side, if it's very alkaline, way up over 7.5, then the alarm bells go off for an infection, which probably means they're struvite stones.
Okay, so while the urine test gives you some amazing clues, it's not the final answer. To really know for sure, the absolute gold standard for diagnosis is a non-contrast CT scan. This thing gives doctors a perfectly clear 3D map of your entire urinary tract. They can see the exact size, the shape, and the location of the stone. No more guessing.
So once they know what they're dealing with, the game plan is actually pretty straightforward, and it all comes down to one thing: size. If the stone is small, less than a centimeter, the approach is usually conservative. That means lots of fluids to flush it out, pain management, and just waiting. But for bigger stones, or ones that are causing complications, you've got to get active. That might mean a procedure that uses sound waves to blast the stone into smaller pieces, or sometimes it means surgery.
Okay, let's shift gears a little. We're moving from blockages caused by stones to another issue doctors are always on the lookout for: silent growths, or tumors. And just like with stones, not all tumors are the same. A really big difference is who they tend to show up in.
When it comes to kidney cancer, there are two main players. And man, the difference between them is stark. On one side, you have Wilms tumor. This is the one you see most often in kids, but the good news is it has a really high survival rate, about 80%. But then you have renal cell carcinoma. This is the most common one in adults, usually hitting people in their 50s and 60s, and the outlook is much tougher, with a 40% 5-year survival rate.
All right, let's play doctor for a second. Picture this. A 50-year-old man walks in. He's suddenly developed a large varicocele. That's like a varicose vein, but in the scrotum, on his left side. Now, that might sound like a plumbing issue, right? A vein thing. But for a urologist, that specific symptom sets off a very particular alarm. Any ideas what they need to check for immediately?
The answer is renal cell carcinoma. Yep, that sudden varicocele can be a classic sign that a tumor in the kidney is blocking a vein. The other huge clues doctors are looking for are obvious: blood in the urine that doesn't cause any pain, that's a major red flag, and of course, being able to actually feel a mass in that area. So far, everything we've talked about develops from inside the body. But what happens when the damage comes from the outside?
Trauma from something like a car crash or a bad fall can do some serious damage to the urinary system.
And when it comes to trauma, the bladder is especially vulnerable. There are two main ways it can rupture. The most common kind is called an extraperitoneal rupture, and it almost always happens when the pelvis gets fractured. But the other kind, an intraperitoneal rupture, is way more dangerous. This happens from a direct, sudden blow to a full bladder. Think a seatbelt in a crash. It causes urine to spill into the abdomen, and it carries a really scary 20% mortality rate.
And for the kidneys, there's a very clear playbook. First, doctors suspect an injury if they see things like pain in the side, blood in the urine, or broken lower ribs. Then, as long as the patient is stable, it's back to our friend the CT scan, this time with contrast to get a clear picture. After that, treatment depends entirely on the grade or the severity of the injury. Most injuries, grades 1 through 4, can often be managed without surgery, but a grade V, that's a shattered kidney, that requires surgery and fast.
And that brings us to our final topic, the prostate. It's a tiny gland that, let's be honest, can cause some pretty big problems, especially as men get older. We're going to look at two conditions that are just incredibly common. Okay, it is so important to get the difference between these two straight. On one side, you have BPH. This is a totally benign, non-cancerous enlargement of the prostate. Let me say it again, it is not a precursor to cancer. Then on the other side, you have adenocarcinoma, which is cancer. But, and this is a big but, it's also important to know that many of these cancers in elderly men are small, they're slow-growing, and they might never actually cause any harm. And just to give you an idea of how common BPH is, look at this number, 75%. That's how many men have BPH by the time they hit 75. This isn't some rare disease. For most guys, it is a completely normal, expected part of getting older. The absolute best way to understand what BPH does is to picture a garden hose with a clamp on it. The prostate gland wraps around the urethra, the tube you pee through. As the prostate gets bigger, it slowly squeezes that hose. And that squeeze is what causes all those classic symptoms. Trouble getting started, a weak stream, and of course, waking up over and over again all night. Now, when there's a worry about prostate cancer, the diagnostic journey follows a pretty logical path. It usually starts with those urinary symptoms we just talked about. That leads to initial screening tests, a PSA blood test, and a digital rectal exam, or DRE. If anything looks off on those, the next step is a biopsy to actually get a tissue sample. And if that comes back positive, the final step is staging, to see how advanced it is. And this right here is the critical takeaway for screening. It's really a two-part check. At any point, if either that PSA blood test or the physical DRE exam is abnormal, the recommendation is crystal clear. It's time to see a urologist. It's all about catching any potential problems as early as humanly possible. So we've really covered a lot of ground, from the sheer agony of a kidney stone to the silent threat of a tumor. We've seen the clues, the signs, and the game plans doctors use. But all of this brings us to the single most important question. The one that only you can answer. Are you really listening to your body? Because at the end of the day, paying attention and being proactive is the best medicine you can possibly have. Thanks so much for tuning in.
Welcome to the deep dive. Today, we're aiming to give you a really efficient path through a topic that can seem, well, pretty complex, urology.
That's the plan.
We've got a great set of source materials here, and our goal really is just to pull out the absolute must-know information for you. Think of it as a shortcut to getting fluent in everything from kidney stones to serious trauma diagnosis.
Exactly. The sources we're drawing from are structured almost like a field guide. We'll cover 4 main areas. First up, urolithiasis, that's the medical term for kidney stones.
Right.
Then we'll tackle the prostate, specifically the difference between benign growth, BPH, and cancer. After that, renal tumors, looking at both adults and kids.
Okay.
And finally, acute urinary trauma, how it's diagnosed and managed quickly. It's a fast track, but we want to make sure these key facts really stick with you.
All right, sounds good. Let's dive in. We should probably start with the one most people have heard of, maybe even experienced kidney stones. When we talk about these little crystalline things, the first question is always, what are they actually made of?
Yeah, good question. If you look at the breakdown, calcium stones, specifically calcium oxalate, they're the big one. They make up about 75% of all cases.
75%. Wow.
Yeah, it's the most common type by far, often tied to things like, hydration, maybe diet.
Okay, so that's the vast majority. But that other 25% sounds important, especially if they need different treatment approaches.
Absolutely.
Oh.
And that's where it gets interesting. Take the struvite stones or triple phosphate stones.
Mm-hmm.
They only account for about 6%, maybe a bit more in some studies.
Okay.
But these are known as infectious stones. Basically, they form because certain bacteria produce ammonia, which makes the urine less acidic, more alkaline, and then magnesium, ammonium, and phosphate start to crystallize.
So linked to an infection.
Right. And here's the really critical part for you to grasp. The bacteria, they get locked inside the stone as it forms.
Inside. So wait, you mean regular antibiotics might not even reach them?
Exactly. That's the challenge. You can give systemic antibiotics, but they often can't get to the bacteria protected within the stone matrix. So treating a struvite stone isn't just about fighting the infection in the urine. You often have to actually get rid of the stone itself to eliminate the source of the bacteria.
That makes perfect sense. If you leave the stone, the bacterial factory just keeps running, right?
Precisely, no matter how many drugs you throw at it. Then, rounding things out, you've got uric acid stones, about 12%, often related to diet, things like high purine intake or conditions like gout.
Okay.
And finally, the really rare ones are cystine stones, maybe 1% or so, usually due to an inherited metabolic disorder.
Got it. So when someone actually has a stone, the symptoms seem to vary a lot. You hear about that agonizing pain, but sometimes not.
Right. It really depends on where the stone is sitting. If it's just chilling out in the kidney, not blocking anything, it might be totally asymptomatic or maybe just a dull, persistent ache in the flank area.
Okay, a dull ache.
But, if that stone decides to take a trip and drops into the ureter, that narrow tube connecting the kidney to the bladder, that's when you get the classic ureteric colic. It's often described as one of the worst pains imaginable. Comes in waves.
Right, the colic. I've heard about that.
And then if it makes it down to the bladder, the pain can change again. Maybe some suprapubic discomfort, sometimes a weird referred pain, like down to the tip of the penis.
That referred pain is fascinating. It really maps the stone's journey. So we have these symptoms, these clues. How do doctors definitively figure out what's going on and what kind of stone it is?
Well, the absolute gold standard these days for diagnosis is a non-contrast CT scan of the renal tract.
Non-contrast, meaning no IV dye.
Correct. You don't need the contrast eye to see most stones. It's super fast, very sensitive, picks up almost all stone types and sizes, and shows exactly where it is.
Okay, CT scan. But you mentioned clues earlier. Can you get any hints even before the scan?
Oh, definitely. A simple urine analysis can give you some really valuable pointers right away. For instance, check the urine pH. If it's high, say, greater than 7.5, that strongly suggests an infection is involved, making you think struvite stone.
Ah, okay. High pH infection, likely.
Yep. Conversely, if the urine is very acidic, like a pH less than 5.5, that points towards uric acid stones.
Wow. So the simple tests, pH and then the CT, really guide the whole management plan.
Absolutely.
So let's talk treatment. What happens once you know there's a stone? How do you decide whether to, wait it out or intervene more actively?
Okay, first things first. If someone comes in with an acute attack, that awful colic pain, the immediate priority is just managing that pain. So strong analgesics, maybe antispasmodics to relax the ureter a bit.
Makes sense. Pain relief first.
Then for the stone itself, the decision usually hinges on size and complications. Is it causing a severe blockage? Is there an infection? If the stone is relatively small, let's say less than a centimeter, and there aren't major complications, we often try conservative management first. That means pushing fluids, lots of water to try and flush it out. Maybe those antispasmodics again, potentially meds to alter the urine pH if it's a uric acid or cystine stone, maybe antibiotics if there's a mild infection, and then just close follow-up. Watchful waiting, basically.
Okay, so small stones, no big problems, you wait and see. But what if it is bigger, like over that centimeter mark? or causing serious issues.
Right. If it crosses that threshold, or if there's significant obstruction, infection, or intractable pain, then we usually move to active treatment.
And what does active mean here? Can you break down those options? You mentioned an acronym earlier.
Yes, ESWL.
Yeah.
That stands for extracorporeal shockwave lithotripsy.
Okay, ESWL.
It's non-invasive.
Yeah.
Basically, high-energy shock waves are generated outside the body, focused on the stone, and they break it up into smaller fragments that can hopefully be passed naturally.
So blasting it from the outside.
Pretty much. But if the stone is very large, very hard, or in a difficult location, ESWL might not work, or we might need a more direct surgical approach. That could be something like percutaneous nephrolithotomy going in through the back directly in the kidney, or ureteroscopy using a scope up the ureter. But yeah, that 1 centimeter size is often a key decider for going active.
That's really clear. Okay, so shifting gears a bit. Kidney stones are often about acute pain. Let's move to something potentially more chronic, more insidious perhaps. Prostate health. This feels really important because we need to sort out BPH from the more serious prostate cancer.
Absolutely crucial distinction. Let's start with BPH. That stands for benign prostatic hyperplasia. And the word benign is key here.
Right. Benign, not cancer.
Exactly. It's a non-cancerous enlargement of the prostate gland, specifically in the zone right around the urethra. And when we talk about how common it is, it's incredibly common.
How common are we talking?
Well, the numbers are pretty staggering. About 75% of men age 75 have some degree of BPH. By age 90, it's over 90%.
Wow, almost universal in older men.
Pretty much. But the most important thing for you to remember and for men to understand is that BPH is not a pre-malignant condition. It doesn't turn into cancer.
That's such a vital point. Huge relief for many, I imagine. So even though it causes a lot of symptoms, it's not cancer risk itself. What are those typical symptoms then, the ones people call prostatism?
It's all down to simple mechanics, really. The enlarged prostate tissue squeezes the urethra, the tube that carries urine out.
Okay, so it's a plumbing problem.
Exactly. That pressure causes difficulty starting the urine stream. That's called hesitancy. Then maybe a weak or forked stream, feeling like you haven't fully emptied, maybe some dribbling afterwards.
Right.
And you can also get irritative symptoms, like needing to go more often, especially at night, that's nocturia, or feeling a sudden strong urge to go, urgency.
Sounds pretty disruptive to daily life. How do you manage that medically? Are there drugs that help?
Yes, thankfully. The mainstays of drug therapy are alpha blockers. These drugs work by relaxing the smooth muscle tissue within the prostate gland itself and also at the bladder neck.
So they don't shrink the prostate, they just relax the squeeze.
Precisely. They improve the flow by reducing that resistance. And here's a neat clinical pull from the sources. One specific alpha blocker, tamsulosin, has a particular advantage.
Oh, yeah. What's that?
It's more selective for the receptors in the prostate and bladder neck, so it tends not to significantly lower systemic blood pressure, unlike some of the older alpha blockers.
Okay. Why is that important?
Well, think about older men. Many already have hypertension, high blood pressure, maybe they're already on medication for it. You don't want to give them a prostate drug that also tanks their blood pressure.
Right. Could cause dizziness, falls.
Exactly. So for hypertensive men, tamsulosin is often preferred because it treats the BPH symptoms without messing with their blood pressure control as much.
That's a fantastic detail. Okay, so that's BPH. Common, benign, manageable with drugs like tamsulosin. Now, let's address the more serious side, prostate adenocarcinoma, or prostate cancer. The sources mention something interesting. Occult cancer is more common than clinical cancer. What does that mean?
It means that while prostate cancer is also common, especially in older men found during autopsy studies, many of these cancers are very small, slow-growing, and might never have caused any symptoms or problems during the man's lifetime. They're occult hidden.
So there's a lot of it, but maybe not all of it is dangerous.
That's the complexity. The challenge is finding the clinically significant cancers, the ones that will grow and potentially spread, while not overdiagnosing or overtreating the insignificant ones. And our current diagnostic tools, well, they have limitations.
What are those tools? How do you look for it?
The standard approach involves a few things. There's the DRE, the digital rectal examination, where the doctor feels the prostate gland.
Okay.
There's the TRUS, or transrectal ultrasound, which gives an image. And then there's the big one people hear about, the PSA blood test. PSA stands for prostate specific antigen. It's a protein made by the prostate. And it can be elevated in cancer, but also in BPH or infection.
Ah, so PSA isn't cancer specific.
Not entirely, no. And critically, as you pointed out from the source, none of these methods, DRE, TRUS, PSA, are totally reliable for detecting those very small, early, potentially insignificant cancers. And the biopsy, which is the definitive test, obviously has its own risks and isn't perfect either.
So it's a tricky balance. What's the standard pathway then if someone has, say, a high PSA or a suspicious DRE?
That's usually the trigger. An abnormal finding on either PSA or DRE generally leads to a referral to a urologist.
Right.
The urologist will then typically recommend a TRUS-guided biopsy, where they take small samples of prostate tissue using ultrasound guidance to check for cancer cells.
And if cancer is found, what about spread?
If adenocarcinoma is confirmed, the next step is staging to see if it has spread beyond the prostate. And here's a key point about prostate cancer metastasis. The most common place it spreads is to the bone.
Bone, okay.
And uniquely, prostate cancer mets in bone are often osteoblastic. That means they cause new bone formation, making the bone appear denser on scans, rather than the more typical osteolytic or destructive lesions seen with many other cancers.
Osteoblastic. That's a really specific detail. Good to know. And screening recommendations.
Standard advice is generally annual prostate exams, including DRE and discussing PSA testing, starting around age 50 or earlier for men at higher risk.
Got it. Okay, moving into our third segment now, we're looking at kidney tumors, contrasting adults and children, and then wrapping up with urinary trauma.
Right. Let's start with the main kidney cancer in adults. RCC, renal cell carcinoma, sometimes called hypernephroma.
RCC, when does that usually show up?
Typically hits people in their 50s and 60s. It's the most common primary kidney malignancy in adults. Clinically, you look for what's sometimes called the classic triad, though not everyone have all three.
What's the triad?
Okay, number one is hematuria, blood in the urine. Often it's frank, meaning visible, painless, and can be quite profuse.
Painless blood. That sounds alarming.
It is. Number two is a palpable mass in the flank or abdomen. And number three, which is a fascinating clue, is sometimes a secondary varicocele.
Varicocele, like enlarged veins in the scrotum. How is that linked to a kidney tumor?
Good question. It's usually on the left side. Remember anatomy. The left gonadal vein drains directly into the left renal vein before heading to the vena cava. The right goes straight to the cava.
Okay, left side drains into the kidney vein.
So if you have a tumor mass in the left kidney, it can compress or block that left renal vein. This causes blood to back up down the left gonadal vein, leading to the enlargement you see as a varicocele.
Wow. So key takeaway. A man, maybe 50s or 60s, who suddenly develops a large left varicocele.
Needs immediate investigation to rule out RCC. It's a classic red flag. Unfortunately, RCC can be quite aggressive. The prognosis isn't great, maybe a 40% 5-year survival overall, so catching it early is critical.
Definitely a key point. Okay, now let's switch gears dramatically to kidney tumors in children.
Right, the main one here is Wilms tumor, also called nephroblastoma. This is actually the most common solid abdominal mass and the most common kidney tumor we see in childhood.
And what age group are we talking about?
Peak incidence is usually between, say, 3 and 5 years old, though the sources mention up to 10. Clinically, it often presents simply as a palpable mass felt in the child's abdomen, maybe some pain or fever too.
Okay. How do you investigate that? Is it CT again?
Well, CT scan, especially with contrast during the portal venous phase, is definitely useful for characterizing the tumor initially. But for staging, figuring out the exact extent, MRI is often preferred.
MRI. Why MRI over CT in kids?
The big advantage is that MRI doesn't use ionizing radiation. In children, you really want to minimize radiation exposure whenever possible. So MRI is generally the investigation of choice for staging Wilms tumor. Also, bone scans aren't typically needed routinely, as bone metastasis is usually a very late event.
Good to know about the imaging preference. And the prognosis. Better than RCC, I hope.
Oh, much better, thankfully. With modern treatment protocols often involving surgery, chemotherapy, and sometimes radiation, the 5-year survival rate for Wilms tumor is up around 80%, maybe even higher for certain stages.
That's great news. Okay, last topic in this segment. Acute urinary trauma. Let's start with the bladder. Where is it vulnerable?
The bladder sits down in the pelvis, mostly extraperitoneal in adults, meaning outside the main abdominal cavity lining. But its dome, the top part, is covered by peritoneum and is considered the weakest point.
Okay, the dome is the weak spot. How does it usually get ruptured?
2 main ways, leading to 2 types of rupture. The most common is extraperitoneal rupture. This happens in like 90 to 100% of cases associated with a pelvic fracture. Bone fragments basically puncture the bladder wall.
So pelvic fracture often means bladder injury check.
Definitely. The second type is intraperitoneal rupture. This is less common, but more dangerous. It usually happens from a sudden blow to the lower abdomen when the bladder is really full.
Like a seatbelt injury in a car crash?
Could be, yeah. The full bladder basically bursts at its weak spot, the dome, and urine spills directly into the peritoneal cavity. This can lead to peritonitis and has a significant mortality rate, maybe around 20%.
Okay, that sounds serious. How do you figure out which type of rupture it is?
The gold standard investigation here is cystography. You instill contrast dye directly into the bladder via a catheter and take X-rays or CT scans to see if the dye leaks out, and if so, where it goes into the pelvic space, extraperitoneal, or up into the abdomen, intraperitoneal.
Cystography, got it. Now what about the kidneys? They're tucked away in the back, right?
They are. They're retroperitoneal organs, cushioned by fat. But they can still be injured, especially with trauma to the back, flank, or lower chest.
So what clues suggest a kidney injury?
You have to suspect it with any significant trauma to those areas, especially if the patient has visible blood in the urine, hematuria, or if there are associated fractures of the lower ribs or the lumbar vertebrae nearby.
Okay. And the go-to investigation, assuming the patient isn't, bleeding out.
Right. If the patient is hemodynamically stable, meaning their blood pressure and heart rate are okay, then the investigation of choice is a contrast-enhanced CT scan.
Contrast this time, unlike the stone scan.
Yes, contrast is crucial here. The IV contrast dye highlights the kidney tissue and blood vessels, allowing you to see lacerations, areas that aren't getting blood flow, infarcts, active bleeding, and any urine leakage. It's the best way to accurately grade the severity of the injury.
And that grading determines treatment, right?
Absolutely. Kidney injuries are graded from I, minor bruise, to V, most severe. Grades 1 and 2 are usually managed conservatively. Bed rest, observation, follow-up imaging.
Okay, wash and wait for minor ones.
For grade V, that means the kidney is basically shattered or the main artery or vein has been torn off, avulsed, that requires surgery, usually removal of the kidney nephrectomy.
Wow. Big difference. Are there absolute must-operate situations?
Yes. The absolute indications for surgery are essentially uncontrollable renal hemorrhage, the patient is unstable and bleeding actively from the kidney, or any penetrating injury, like a gunshot or stab wound, that involves the kidney's collecting system or major vessels.
Makes sense. Uncontrolled bleeding or a penetrating wound needs surgical exploration.
Exactly.
Okay, well, that was a really packed deep dive. We went from common things like calcium oxalate stones and the need to actually remove struvite stone.
Right, getting the source of infection out.
All the way to those critical red flags, like a sudden left varicocele possibly indicating RCC, and the different management grades for kidney trauma.
And hopefully you picked up on the key diagnostic tools for each scenario. It's often about choosing the right imaging at the right time.
Mm-hmm.
Non-contrast CT for stones.
Right.
Cystography specifically for bladder rupture. Contrast CT for kidney trauma assessment. And that combo of DRE, PSA, and potentially biopsy for the prostate.
Definitely. And maybe one final thought to leave you with, looping back to the prostate. We heard BPH is incredibly common, almost universal in older men, but it's benign.
Mm-hmm.
We also heard that screening tools like DRE and PSA aren't perfect, especially for finding those small, maybe insignificant cancers.
True.
So here's the question. Given how widespread BPH is and how it physically changes the prostate and can affect PSA levels itself, how much does that really common benign condition complicate things? Does it potentially mask or delay the diagnosis of those smaller, maybe clinically important prostate cancers?
That's a really good question. The overlap in symptoms, the effect on PSA, it definitely muddies the waters.
Something for you to chew on as you process this deep dive.